Good morning, everyone. We are going to get started because I know that people have busy schedules. So my name is Hilary Dubois, and I am the director of the Brockton Area Prevention Collaborative. Joining me today are my colleagues, Gabby Peruccio, Dave Capozzi, and Amanda Sandoval. This is on Zoom webinar, so if you're not familiar with this platform, you will see us as hosts, but you won't see your picture, we don't see your video or anything like that. If you have any questions or information that you would like to answer anonymously, at the top or bottom of your screen, you'll see a little Q&A bubble. You can ask a question there and it'll be anonymous. If you go to the chat feature, that's something everyone will see, and we can answer questions for you either way. We are recording this training, so hopefully it'll be made available. We have 2 more trainings this week, and they are the exact same trainings that we are doing today. So if you've inadvertently signed up for all 3, they're going to be the same information, and you can just enjoy today and not feel like you need to participate in the other ones. So today's training is on overdose prevention, how to save lives in the new normal. It's basically taking our traditional overdose prevention training and updating it with some really important, relevant information that we're hoping that folks can know as we are continuing to navigate this new normal, these unprecedented times that we hear so often. So we will also have some polls throughout and some opportunities for folks to get involved and engaged in our work if you're interested to do so. So this is our overview of today's discussion. We're going to talk about what are opioids, what's an overdose. We're going to talk about the scope of the problem, what puts people at risk, what are some signs of an overdose, how to manage overdose, what naloxone is, and what are some local resources. So I think Dave's going to pop in our first poll question, and we're going to give everyone a few seconds. So you can just answer it. This is all anonymous. We won't know how anyone has answered. So give everyone just 1-2 more seconds. Okay. So when we look at if whoever has completed an overdose prevention training, the vast majority of you haven't. This is your first time. Welcome. It's wonderful to see. So this is February 1st. I hit 11 years doing overdose prevention work in the greater Brockton area. And if I had asked this question 11 years ago, the vast majority of people would have said they'd never heard of naloxone. So 90% of you guys have. And about 43% feel comfortable administering Narcan. And hopefully by the end of this, we can give you some information that will put you at ease to administer naloxone should you ever be in a situation where you need to. So we're going to zoom back out. One of the things that a lot of people don't know is that we want to spread our information wide and get this information in the hands of as many people as possible. We actually have translations available for folks who don't speak English. We have a ton of written handouts about opioid overdose and other health equity issues around substance use and information around substance use. We regularly have our information translated into Latin American Spanish, Brazilian Portuguese, and Haitian Creole. And if you're ever interested in getting a hold of some of our translated copies or resources, please reach out to us. If you work with a population in the greater Brockton area and you would need something in another language, please reach out. We would be happy to get something translated for you. So we have the printed resources in other languages right now, and we're also working on doing this training and uploading it, or similar training and uploading it to YouTube in Latin American Spanish, Brazilian Portuguese, and Haitian Creole. So check out those and reach out if you need those translations. So the state of the matter. Let's talk a little bit about where we are here in Plymouth County. Dave's gonna put up a poll so we can find out some information about where you all are joining us from. give it another second and see if anybody else wants to answer our questions. And we'll end it. Okay, so this is going to come back as to why we're asking these questions. So it looks like we're about 50-50 split on who lives in Plymouth County. The majority of you guys are employed, and we're going to talk about why we're asking that question as we get towards the end of our program, and who works in Plymouth County, so about a third do. And we're doing a very specific project with local businesses, so that's why we're looking for that information. So if we zoom into Plymouth County, we got this data from Plymouth County Outreach. Plymouth County Outreach is a police-assisted outreach that provides support after fatal and non-fatal overdoses in any town in Plymouth County and the city of Brockton, which is also within Plymouth County. And they also do at-risk referrals. So if you or a loved one or a friend has someone in their lives who's struggling with substance use, they can actually go into a police department and say, I'm looking for help, can you please help me? And they will work with a recovery coach to try to provide individuals with support. So one thing I can tell you about data, particularly around overdoses, is it's a delayed process for us to get data. So what we'll continue to see is over the course of 2021, more fatal overdoses will clear through the medical examiner's offices. But if we look at presently here in Plymouth County Outreach reports that they had 153 fatal overdoses throughout the county. They had responded to 1,063 non-fatal overdoses, and they had 199 at-risk referrals. So these numbers are up slightly from last year, from 2019. What we hope to see is an increase in the amount of at-risk referrals. So those are people who are self-selecting and identifying and looking for help. And again, you can go to any police department in Plymouth County, including Bridgewater State University, and ask for help, and they will link you to services. So COVID-19 and addiction. There's a couple of different areas that we wanted to include in this training that are all relevant to substance use and COVID. COVID has impacted our lives in so many ways, and all of that deeply impacts how it integrates with substance use on a lot of different levels. So if we look at the complications from COVID, treatment beds are congregate care units, and so they have been limiting bed capacity throughout the state, as well as there have been some semi-permanent and permanent closures for treatment beds. So basically, treatments require to have social distancing measures, which reduces the amount of patients that can come in that they can safely treat. And it's challenging for people to get beds. So what our recommendation is for individuals who are really, really looking to get an inpatient treatment bed is just to continue to call, be thorough, maybe reach out to your local police department or reach out to other places that help and support. We'll talk a little bit more about that to try to get extra support in finding a treatment bed if that's necessary for a loved one. So that's on the substance use disorder side of the coin. If we look at our other medical patients, as a result of COVID-19, a lot of people who experience chronic pain or were in need of surgeries to alleviate pain have been pushed off when there's been either spikes or when we were in lockdown. So basically, for people who are dealing with significant pain, the only way for them to potentially have pain management is through an increased prescribing of opioid. Which puts, again, more prescription pills out into the community. The other thing that happened, particularly during lockdown, is alternative options for pain management. So like physical therapy or acupuncture or other alternatives. People might not have had access to those. Their clinics might have been shut down. They might not have been a priority patient. So basically what that leads to is more opioids being prescribed. Also, the individuals are self-medicating right now to cope with the stressors that are associated with COVID more than ever. Alcohol sales are up, and people are looking for easy ways to deal with the incredible amount of stressors, fear, anxiety, unemployment, stress, all of the different emotional experiences, grief that have come along with the COVID-19 pandemic, increased people trying to look to self-medicate as a way to use it as a coping skills to get through the pandemic. And then particularly when we're looking at our friends and our loved ones who are in recovery, isolation of individuals within the recovery community, particularly those who utilize 12-step programs, has caused a deep sense of isolation, which has been extraordinarily negative to folks who are in recovery, who rely on that network of connectedness in order to stay sober. And unfortunately, as a result of that, we're seeing a high number of fatal overdoses being within people who've had periods of sobriety, long periods of sobriety, multiple years that they've put together. So it's definitely had a very significant negative impact on our recovery communities. So we look at the challenges that are associated with COVID and substance use. One of the biggest ones is when we're looking at what the symptoms of COVID are, they're flu-like symptoms. Well, those are also the same symptoms you're going to have when someone has opioid withdrawal. So it confuses the situation. Is someone withdrawing or do they have COVID? When a patient goes in to go into a treatment, bed, an inpatient treatment bed, is it COVID or is it withdrawal? So it just sort of confuses the situation more. Also, people who use depressants such as alcohol, benzodiazepines, or opioids are at an increased risk of having complications from COVID because of how depressants impact someone's ability to get oxygen. So it definitely can be a very negative when you're looking at risk factors. Yale University School of Medicine has a very comprehensive guidance document. We can also send it in a follow-up email. They've got a great guidance document on harm reduction strategies. So harm reductions are tools or strategies that reduce the risk of death in someone who's unable or unwilling to stop using. And they put out a great 3-page document on the impact of COVID and overdose. And they have a bunch of different harm reduction strategies that both reduce the risk of dying from an overdose and risks of contracting COVID while continuing to use substances. And then it changed the way that we recommend that people respond to overdoses. So though rescue breathing is one of the most critical ways to save someone's life from an overdose, mouth to mouth puts someone at the highest risk for COVID transmission. So for folks who are working in the field or have access to it, the optimal way to respond to an overdose where you shouldn't use mouth to mouth is to use a bag, valve, mask, an ambu bag, something like that. So I know Amanda just shared the guidance document in the chat. So definitely click on that. It's a great bit of information if you're interested in harm reduction. So we've definitely had to look to changing how we would traditionally talk about overdose and how we would traditionally talk about substance use sort of in the confines of the new normal. So what is an overdose? Let's talk about what are opioids first. So opioids are central nervous system depressants. They depress and repress someone's ability to get oxygen. Our primary illegal opioid when we're thinking about it would be heroin. Heroin is derived from the opium poppy, and it's our primary illegal opioid. But otherwise, when we talk about opioids, we're talking about something that either is derived from the opium poppy or something that's synthetically manufactured by a drug company that mimics the chemical formula of what you would find in something that came from the opium poppy. So examples of those are things like Percocet, oxycodone, which is the active ingredient in both Percocet and OxyContin, hydrocodone, which is the active ingredient in Vicodin, fentanyl, which is the most potent prescription opioid, which really, when we talk about what we see in southeastern Mass, what's referred to as heroin on the streets is really fentanyl, which can be anywhere up to 5,000 times more potent than actual pure heroin. And that's been the case at this point, I think, for about 4 or 5 years. Other examples are like Dilaudid, or even drugs that are used in medication for opioid use disorders, or forms of MAT, which is medication-assisted treatment. So those could be drugs like Subutex, methadone, and they basically go in our brain and they reduce someone's cravings to continue to use opioids. But really, regardless of the nature of the opioid, when it goes into the person's brain, our brain can't tell the difference between Percocet or codeine or heroin. It all acts on receptors the same way. Another thing that I think is important to talk about is, 10, 11 years ago when I first started doing this work, and we talked about prescription pills that people were buying and selling on the streets, they all had legitimate origins. They were diverted from pharmacies or stolen from someone's prescription bottle. In southeastern Massachusetts, when we're talking about pills that are bought and sold on the streets, we can't assume that they have legitimate origins. There are people who basically make knockoff pills. They buy pill presses on the internet and they take whatever they have and they press it into a pill. So they sell it to someone thinking that it's a legitimate pill and it's made up of who knows what. So these are definitely issues that impact our local, regional context and understanding of what opioids and opioid overdose looks like in our region. So what is an overdose? An overdose is basically these drugs fit into receptors in our brain, and it's like a lock and key situation. And the opioid unlocks all of these feel-good chemicals in our brain. But the problem is that when you have too many opioids in too many brain receptors, our brain doesn't have the ability to do what it's meant to do and to send a message throughout the body to tell the person to continue to breathe. So ultimately what we look at as an overdose is basically someone going into respiratory arrest. So the brain's too busy processing the opioid, it doesn't send the message for the person to continue to breathe, and without oxygen, all of our vital organs start to shut down. So our heart, our liver, our lungs, our kidneys, our brain all require oxygen for the person to live, basically. So what's important to know is dependent on what someone has taken, that determines how long the onset for an overdose can happen. A drug like methadone has a very long half-life. It's meant to be taken once a day to prevent someone from going and having cravings and going into withdrawal. So a drug like methadone has a really long half-life in our brain and in our body. So someone could have a delayed response to having an overdose and needs to be watched much closer and for a much longer period of time if it's believed that it's a methadone overdose. We used to talk about prescription pills, legal prescription pills and heroin as having a delayed onset of 1 to 3 hours that it could take for someone to overdose. But truly, when you brought fentanyl into the mix, people were overdosing much more quickly on much smaller amounts. So the truth of the matter is when we look at how long it could take for someone to overdose, it could be less than a minute up to hours. We hear oftentimes about people going to bed and being fine and not waking up and overdosing in their sleep. That's definitely a possibility. And it creates a confusing dynamic because you can overdose minutes after use or you can overdose hours after use. And it's really important for people to know that. So these are last year's statistics. Opioid overdose is the leading cause of unnatural death in the United States and has been since 2012. In 2019, they were able to confirm 1,543 fatal overdoses. Like I told you earlier, it's going to take a little bit longer for our numbers to settle out. And on average, 5 people are dying every day in the state of Massachusetts from opioid overdose. But people who are actively trained, know how to respond, have access to naloxone, can significantly reduce that number and can save lives. So, what puts you at risk? This is really important to understand. What are the different factors that put people at risk for an overdose? One of them is mixing drugs. We call it polysubstance use, but really when you put multiple substances into your body, legal or illegal, you're not adding one thing to the next, you're multiplying the effects of each and everything that you use. It is not an uncommon thing to see someone who uses benzodiazepines, so drugs like Xanax, Ativan, Valium, and Klonopin, who also use drugs like heroin or fentanyl or prescription pills. And benzodiazepines are also depressants, so they're going to slow down the body even faster. But you'll also find people who like to use stimulants and depressants, so that might be cocaine, or that could be a prescription drug like Adderall, and they mix it. And basically they're speeding up their heart while they're slowing down their ability to get oxygen. But either way, it's a multiplication effect, not an addition effect. Tolerance is another huge impact. I spoke a little bit earlier about how we're seeing folks in long-term recovery having a brief relapse and overdosing and dying. So we know that these drugs are drugs of tolerance, meaning the more you use, the more you need to use to not go into withdrawal and in turn to be able to get high. But one of the things people often don't take into consideration is that for every day that someone doesn't use, their tolerance drops. And so even things like going to treatment can increase someone's risk for an overdose, because every day that they're in treatment is a day that they're not using. So they're actually losing their tolerance. So if they go out and they think that they can use the same way they were using before, it's different. Their body can't handle it the same way. So for every day that someone doesn't use, whether they're in treatment or jail or they have a long-term period of sobriety, if they pick up and use again, their body just doesn't know how to process it the same way that they're used to. Quality control and fluctuations in the purity of drugs both relate to illegal drugs, right? So that's either our heroin or our fentanyl or those pressed pills. And really, it varies from community to community. In some situations, it's one side of a city to the next. What you get in Boston is very different from what you get in Brockton is very different than what you would get in Nantucket. So, and it ebbs and it flows, and it ebbs and it flows very quickly. That then relates to overdose clusters. So for those of us in sound, sober mind, we can't really understand this, but for folks who are in active addiction, after a period of time, people aren't really even getting high from the substances that they're using. They're just using to not go into the miserable, horrible experience of withdrawal. So when they hear that someone locally has died of an overdose, they actually seek out the source of that drug. Now, for us in a sober, clear-headed mind, that makes no sense. It would seem like that would say to the person, this is dangerous and you should stay away from it. But for people who are in active addiction, what it says is if that stuff was good enough to kill someone, I will get high, I will experience euphoria. And for a lot of people, they're just using every day not to go into withdrawal. So they actually seek out the source of that drug, and we tend to see that there'll be overdose clusters. If someone's had a previous overdose, it's not even necessarily that they've damaged their brain or they've damaged their body. It has a lot to do with that they've removed a kind of subconscious barrier of fear. Overdoses are accidental deaths when someone dies. So basically, if someone's overdosed in the past, they've removed this barrier of fear and might be a little bit more risky in their use. Again, we would think it would be the opposite, but not in a brain that is being controlled by substances. And then physical health, and yes, this definitely relates back to our conversation about COVID. Anything that negatively impacts someone's ability to get oxygen will increase their likelihood of dying from an overdose. So that could be COVID, but that could also be seasonal allergies or asthma or the flu or cold. Also, typically when people are in active addiction, they're not eating properly, they're not getting adequate sleep, they're not hydrated, they're not going to the PCP and you know, doing all their follow-up medical stuff. So anything that decreases the health and wellness of a body will increase the person's likelihood of having an overdose. So what does an overdose, what does an overdose look like? We're gonna have Dave toss in a poll. So this one's only one question. Okay, so we're at about a 50-50 split with some people not being sure. So Probably reasons you suspected an overdose are because someone doesn't look right. And the signs of an overdose on any depressant really ranges significantly. The most confusing sign of an overdose is someone is still awake, they're still up, walking and talking, but they're unable to respond. So they might be walking into furniture or walls, they might be talking, but they're not engaging in a conversation. If someone cannot look and respond back to you, they could be in an overdose. So that's the most confusing sign, because we tend to write that person off, but the person will continue to go into an overdose and their body's basically been fighting it. The most obvious sign of an overdose is a blue tinge to the lips, fingertips, and in someone pale like me, at the tops of the ears. It is a range dependent on the person's complexion. So in someone who's very pale, it would be a very vibrant blue. To someone who has very dark skin, it might appear just black, and it's, you know, colors of blue and purple in between. Otherwise, their skin is going to be gray, pale, or ashen. If you were to touch their skin, it would feel cool and clammy. Their breathing would be slow, stopped, or erratic. They could be making a choking, gurgling, or even exaggerated snoring sound. They could be throwing up or passing out or foaming at the lips. These are all signs of overdoses from any depressant, so alcohol, benzodiazepines, or opioids. Whereas when someone's really high, their speech is slow and slurred, they're sleepy looking, they're in a dreamlike state, they might be nodding, but the big difference between someone who's really high and someone who's in an overdose is someone who's just really high should be able to respond to you. They should be able to, it might be a little delayed, but they should be able to respond to a question. Whereas when someone's in an overdose, they won't respond to you. So, how do you respond? Our overdose management skills are to assess the signs. So if someone's not looking right, you're going to try to talk to them, say their name loudly. If they're not responding to you, you're going to go to stimulation. So what stimulation is we predominantly recommend the sternal rub. So that's knuckles hard up and down on the breastbone. If you don't feel comfortable touching someone's chest or they've got a lot of layers on, you can go below the nose and above the upper lip. It's the same super uncomfortable bone-on-bone reaction. If they don't respond to that, it's very fair to say that they're out. The next thing you want to do is call 911 immediately. You want them on their way, driving to you as you're doing any of the next steps. Like we said earlier, rescue breaths is the #1 sort of gold standard for treatment. If you don't feel comfortable putting your mouth on someone, you can start doing chest compressions, which was traditionally something we would tell you not to do. If you don't have an ambu bag, you can continue moving on and administering naloxone if you have it, which is why now with people being uncomfortable to put mouth on mouth, you really want to make sure you have access to naloxone. Because if you don't want to do mouth to mouth, you'd want to administer it. Now, there's different people in all of our lives, right? So we might not be willing to do rescue breaths to a client or a stranger, but we might definitely be willing to do rescue breaths on a loved one. So understanding that there is a range of different people in our lives. But if we have access to naloxone and we've called 911, that will save someone's life. And then naloxone, also known by its shorter trade name of Narcan. You have to leave someone for any reason. You have to grab your phone, you have to get backup, you have to call 911. You want to leave the person on the ground in this position with the leg crossed over the person's body, the head supported, open and pointed downward. Like I said earlier, people do vomit and foam at the mouth in an overdose. You don't want them to choke on that or to drown on it. So you want to make sure that they're in a secure, safe place if you have to leave the person for any reason. For everything else, whether you would use the ambu bag or you would do mouth to mouth, you would want them flat on their back. Rescue breathing, if it's someone that you're willing to do mouth to mouth on, you would tilt up their chin, pinch their nose, put your mouth over theirs, and give them 2 slow, deep breaths. You want to see the chest rise and not the stomach. If you see the stomach rise, you need to tilt the chin back higher. If you have access to a valve, mask, manual resuscitator, ambu bag, as they're known as, you would definitely want to make sure you have that on hand. So if any of you guys are coming from an agency or a company that would potentially be wanting you to use this on an individual, ask them if they can get a manual respirator so that you have it in your first aid kit with your Narcan. So what is Narcan? So Narcan is a trade name for the drug naloxone. Naloxone is a medication that reverses the effects of an overdose. So if you're uncomfortable with doing mouth-to-mouth on someone, doing Narcan would be the next best thing. So in a normal situation outside of COVID, we would tell someone to give someone 2 rescue breaths, to administer Narcan, look for improved signs of life, and if you don't see that, to continue rescue breathing for about 3 to 5 minutes and continue to provide Narcan. So Narcan displaces the opioid in the brain and acts as a blocker. It doesn't dissolve the opioid in their brain, it simply displaces it. It lasts for about 20 minutes. It could last up to 90 minutes depending on what the person's taken. But the person can re-overdose because the opioids will go back into the receptor after the Narcan wears off. So you want them in the hospital. They typically would be monitored for about 3 to 4 hours. I have a child who has a long-standing history of going into anaphylaxis. I equate Narcan just like I equate my son's EpiPen. If I have to give my son an EpiPen, he goes in an ambulance and goes to the hospital where they would typically monitor him for about 3 to 4 hours. Really, Narcan's the exact same thing. Speaking of allergies, it's safe and effective. There's really no known allergies that people have to it. So you can't hurt somebody by giving them Narcan. In a lot of cases, people, based on the situation, maybe if I went out and I was unresponsive, maybe based on my age or maybe based on whatever, the paramedics might administer Narcan to me. And if I have a positive response, they know that opioids were involved in some way in an overdose. And if I have no response, then they kind of continue on their diagnostic way. You cannot hurt somebody by giving them Narcan. In fact, there's a state law that says if you administer naloxone to someone in good faith, you're protected from any potential liability. If they're not overdosing, you're not going to hurt the person, you're just going to give them a runny nose. So law enforcement carries it, a lot of businesses have it because there's no liability to giving it to someone you could just potentially save their life. So there's no potential for abuse, you can't get high from this stuff, it's legal to carry, and we recommend that people store it at room temperature. This is a picture of it. You would get 2 doses, each are 4 milligrams in 0.1 milliliter of fluid, so it's a tiny amount. You put it in the person's nose, you push it up through the nose, it goes into the brain, removes the opioids from the receptors. You want to wait about 2 to 3 minutes between doses to allow it to work, because otherwise you're kind of creating too much competition in the brain with stuff pinging all over the place, is at least how I imagine it. But you can give someone multiple doses of Narcan. There's no such thing as giving someone too much Narcan. If you were to give someone Narcan while you're waiting for 911 to come and you've given them it intranasally, when EMS comes, they'll probably give it to them in an intramuscular shot or potentially even in an IV drip. So it's totally safe. There's no potentials of harming someone by giving it to them. How to get it. So if you're local to the Brockton area, you can get it through BAMSI's COPE Center. You can also get it through Learn to Cope, which is an amazing family support group that helps people who have loved ones who are impacted by substance use, or you can get it at your local pharmacy. Basically, they'll bill your insurance for it. You don't need a prescription for it. You can just walk in and say, I'd like to get naloxone. They'll run it through your insurance and they'll have it. I get my prescriptions filled at a CVS and there's signs saying we have Narcan here. So people who have access, who are still going to their pharmacies, definitely can get it that way. I always recommend too, if you have anyone in your household who regularly is prescribed opioids, to have it on hand because they could be overprescribed or mess up their dosage or things like that. Lastly, our local resources. So regionally, we have High Point Treatment Center located in southeastern Mass. We are all staff of High Point through their prevention services program. They have inpatient, outpatient, telehealth, medication, assisted treatment, the whole continuum of care. The Champion Plan, which is located in Brockton, but you do not need to live in Brockton. You would go to the police department and they will work with folks in the field to assist in linkage to treatment, and they do amazing follow-up work. Plymouth County Outreach, which I talked about, they have 24/7 recovery coaches, so you can go into your local police department if you are in Plymouth County and engage with them that way. You can also help us to help other people. We would love it if you guys could take a moment to fill out this survey in our last few minutes of the training. Dave's going to put it in the chat box. So the reason why we asked who works and where you work and do you work in our area is we're trying to outreach with businesses. Businesses have been our essential employees through all of the pandemic, and we've seen how important they are to our communities, how important they are to keeping us all healthy and safe. And what we're trying to work with our local business community and get them trained in opioid overdose prevention and to have naloxone on hand. So we have a whole beautiful, wonderful manual that we've created. We have all of our stuff translated, and we can bring this training and Narcan to our local business communities. So if you know a business, you own a business, you work for a local business, or you could help connect us to a local business, please do. And we would love to come out, train your staff, and also to support and recognize our local businesses in their effort to keep our communities safe and healthy. So please help us to help other people. For statewide resources, we have Learn to Cope. Learn to Cope is an unbelievable family support, and it's peer-to-peer. If you're familiar with Al-Anon, so it's kind of like that, but it also has a lot of resources and really great information. They have a wonderful website. They've also done incredible advocacy work. They're a wonderful group of parents and family members and loved ones of people who've been impacted by substance use. So if you're looking for support for yourself or for a friend or someone, definitely connect with them. And then there's the Massachusetts Substance Use Hotline. It's really more of a helpline than a hotline, but you can go to their website and they can help to connect you to resources and services, particularly in this challenging time of trying to find treatment. And then you can connect with us. Okay, so we are the Brockton Area Prevention Collaborative. We don't treat the individual, we treat the community. We work to engage, empower, and connect to address substance use. You guys have all done that with us today, and we so appreciate you joining us. You can go to our website, which is opioidoverdoseprevention.org. We are sort of the OGs in the local area when it comes to overdose prevention. We have a lot of great information out there. If you're on Facebook, please follow us at Brockton Area Prevention Collaborative on Facebook. We are regularly involved in sharing information and different events and things that we work on. If you're on the gram, you can follow us at OD_preventionist. And we, again, also regularly post there. And so with that, that concludes our presentation. We so appreciate you all for joining us. And if you have any questions, you can drop them in the chat or in the questions and answers, and we'd be happy to answer them. Thank you so much. Can you go over what to do when someone is overdosing in non-COVID times? Sure. So in non-COVID times, what you would do is you'd assess the signs like we talked about. So the person, how do they look, right? How does their color look? How does their breathing look? Are they snoring? Whatever. You would maybe say their name loudly. If they're not responsive to you, you would do that sternal rub on the chest, below the nose, and above the upper lip. Then you would call 911. That's definitely always your first thing that you want to do, because you want EMS to be on their way while you're continuing, because every second, every minute is critically important. Then what you would do is you would do rescue breathing outside of COVID, okay? Mouth to mouth. If you had a simple barrier, it could be a t-shirt if you don't want to put your lips on someone. Again, like I discussed earlier, there's a big difference between a stranger and a loved one. So if it's someone you love, you're going to do mouth to mouth. You don't need a barrier. But certainly you can put a barrier as a layer, like a layer of a t-shirt or whatever, in between your mouth and theirs. So You would first check to see if there's anything in their airway, use your pointer finger like a hook to pull it out. Otherwise, while they're flat on their back, tilt the chin up, pinch the nose, put your mouth over theirs, and give them 2 slow, deep breaths. You want to see the chest rise and not the stomach. If you blow air into the stomach, it's not helping you. So as long as the chest rises, you're going to do the 2 rescue breaths. Then what you're going to do is administer the naloxone, right? So just put it in the nose and push. And then you're going to take a step back. And in real time, you're going to feel like time has stopped. But you want to look and see if you have improved signs of life for about 20 seconds. If you don't see any improved signs of life, you're going to go and continue to rescue breathe 1 breath every 5 seconds, either until help arrives or until about 3 minutes has gone by, which is going to feel like a lifetime. If after about 3 minutes have gone by, you don't see any improved signs of life, you could administer a second dose of naloxone, again, just right up the nose, and you would continue to do that, okay? So you want to wait about 3 minutes between each dose of Narcan, and you want to breathe in between each dose, giving about a 20-second, 30-second window to see if you're going to see any improved signs of life. That's all well and good for me to say, but if it's someone you care about or someone you love, each second that goes by feels like an hour, but you definitely want to try to wait in between doses because otherwise you don't get the full effect of how the medication works.